It's such an honor to be here, and especially to be part of this group that are honoring Camille for the work that she did along with Bob and Sue in terms of the beginning of this whole journey to bring about this transformation in primary care. And I think that we are in a time where we've realized, due to the pandemic, the challenges that face healthcare in general, but especially primary care. And I'm hoping that primary care does come out stronger at the end of this whole journey. So with that, I'd like to have my colleague here, Bob Phillips, go ahead and do his presentation on the past, present, and future of primary care. Thank you.
Thank you so much. And yes, and Sue, thank you for that kind introduction too. I have to say, I'm very honored to be participating in this lectureship in Camille's name. One of my staff, who I hired 15 years ago at the Robert Graham Center, she's a geospatial analyst and very good. But when she saw that I was doing this talk, she said, please give my regards to Camille, because she's one of my mentors and worked with me at TPCC and helped me in grad school. So your reach is long in time and in distance, Camille, thank you. The other thing I want to do is congratulate you. 10 years of working at this difficult task, and that timeline was so impressive for what you have put together all along the way. I hope our time has come. Absolutely, Dan. So I'm going to come back to the National Academy's report that Jackson Griggs was a big part of. I'm so grateful for his contribution there. I'm going to come back to this report because it really is where I think we have our next best opportunities to take primary care to a new level. And it really is about rebuilding the foundation of healthcare. It came out in May of 21, so more than a year ago, but it is having some really important impacts even now. But first I want to take you back to some of the past. So in 1961, Carr White published a study in the New England Journal of Medicine called The Ecology of Medical Care. And what he showed that is, if you look at 1,000 people in an average month, about 800 will tell you that they have some symptoms. About a third of them will seek care for those symptoms, most of them in a physician's office, and most of those in primary care. But as we came forward 40 years, about 65 said they paid cash out of pocket for a complementary or alternative medicine provider. 21 went to a hospital-based clinic. 14 got care in their home, 13 in the emergency room, 8 were hospitalized, and less than 1 in 1,000 wound up in an academic health center. If you look at the studies from 61 and 2001, there is almost no difference. Almost no difference in the patterns of people feeling like they need care and care-seeking behavior and where they get care. And in fact, if you come forward just a few more years, there was a good comparison using the same data sets from 1996 and 2012. And if there's no deviation, you'd expect the dots to all line up just like they do. And very similar to what we found in 2001. So again, these patterns are very intransigent. No matter what's happening in the health system, people are seeking care in the very same places typically. And that's important to know because there's lots of claims about people seeking care in different ways, and it really, for 60 years, it has not changed. In fact, the Graham Center has put together a really nice chart book of facts and statistics, and this is from 14. If you look at 16 or 18 data, which are the latest ones available, between 800 million and a billion visits are made per year in the United States in the outpatient setting, about half in primary care. And if you take away surgical subspecialties, it is still the dominant platform for healthcare. It is where most care is delivered. And I bring that up very specifically because if you look at the 2017 epidemic report, the plan for the federal government about how it would deal with a pandemic, it mentioned primary care once. And it was a footnote explaining what the specialties were that made up primary care. So it's no wonder that a federal response to a pandemic did not have a primary care strategy where most people have healthcare relationships, where they go for care, and where most people actually get their vaccines. Going back to the past, I also want to take you back to Barbara Starfield, and some of you may have met Barbara. Barbara was really, she was a fabulous researcher, but she knew how to turn data into digestible information, and she was known all around the world for this. She was the chair of the Department of Health Policy and Management at Johns Hopkins, a pediatrician by training, and she had a huge influence on health services research. She was actually trained by Carr White, who did those ecology boxes, and so her frame was at a population national level throughout her career. But she took great pains to tease out the specifics. So she talks about primary care and generalism as being quite distinct from specialism, that we focus on breadth, whereas subspecialists tend to focus on depth. We're multidisciplinary or integrated. They tend to be very single specialty or single discipline. We get lots of undifferentiated symptoms walk through our door. They get lots of more differentiated because we do the work up front of helping them narrow down what they're looking at. So there's these important differences between generalism and specialism, which in healthcare have really been neglected. But in general, I don't know if any of you have read Range, Why Generalists Triumph in a Specialized World, but if you just read the first couple chapters, generalism is kind of an ascendancy in this country, not just in healthcare, I shouldn't say not in healthcare, but everywhere else, because it is so valued and for what it does. I'd encourage you to look at this book if you're in primary care, because it really speaks to what we do every day. So I'm actually going to use some of Barbara's slides that I thought were more important for this discussion. So this is her definition from 2007, that primary care is the provision of first contact, person-focused, ongoing care over time, to Camille's point. Nothing good happens in a short amount of time in healthcare, that meets the health-related needs of people, referring only those too uncommon to maintain competence and coordinate care when people receive services at other levels of care. Now, Barbara was part of the 1996 Institute of Medicine report on primary care that most of the people who were involved in said was really important and had almost no impact. And the definition in that report is not too different from the one that Barbara was using in 2007. But those elements in that definition can be broken down into measurable things. And I don't know about your value-based contracts, but my value-based contracts do not typically list these kinds of measures about first contact, about continuity or comprehensiveness or care coordination. They're just not part of what I'm valued for. And it's really hard to work at this when you're being paid for and judged by something else. I put a parentheses next to longitudinality, and I'll come back to it in a second because it's important. Continuity is used a lot. There's a lot of research about the value of continuity. When you measurize it, it tends to get stuck in a one-year frame. And Barbara felt that that wasn't good enough, that longitudinality, the relationships that we have in healthcare tend to be longer than a year, and that's where they really have their therapeutic value. You can go all the way back to Francis Peabody in 1927. I'm sure some of you have read this really famous essay that was in JAMA. But he said that the good physician knows his patient through and through, and his knowledge is bought dearly. For the secret of the care of the patient is in caring for the patient. That speaks to the relationship and the value of relationship and ownership and accountability for people's health outcomes. And Barbara was really specific. She said, continuity is a mechanism to achieve knowledge. But longitudinality, that continuity over time, is the mechanism for achieving understanding. And if you can reach that longitudinal level of understanding with patients, you can be much more effective as their clinician. She was also a big fan of comprehensiveness, and she said comprehensiveness in primary care is necessary and to avoid unnecessary referrals to specialists, especially in people with complex health conditions. So, can we manage most of what people need managed in our setting without just triaging and passing them off to other settings? And she was also very specific about measuring it. She said you can measure it or assess it by looking at the services that are provided, or you can look at it in terms of the range of conditions that people have, and not just on their problem list, but that are added to every visit. These are the things I addressed in this visit. So several of us have worked at measuring comprehensiveness from both services or range of diagnoses for patients as a way to measurize it. Barbara and her team at Hopkins actually did measurize this. They called it the Primary Care Assessment Tool, or PCAT, and it had each of these elements that were in the definition. It actually got used in many countries for a long time. It's not used consistently in the United States except in a very small number of clinics. But it is a way to measure what the value proposition of primary care if value-based payment wanted to use it. And that's where my center has really been working in one of its efforts, and that is around getting value-based care to the value that we offer. In fact, our tagline on there is we aim to align the values of the health professions with how they are valued. Because it's the misalignment of those that produces so much burnout for us. Because you, as a professional, are trying to do one thing when you're being measured or paid on another. And I'd invite you to take a look at our website. We have a national primary care registry that has about 650 practices. It touches people in all 50 states. And I bring that up because it's become an important laboratory for us. And because it has some authorities under CMS, we actually can test and develop measures in it and start to move them out into the value-based space even before we start to run the gauntlet of endorsement with the National Quality Forum or with CMS. So it's been an important place for us to get feedback on physicians and nurse practitioners and PAs' experiences with this. And I bring up comprehensiveness and continuity again because when I was with the Graham Center and after, we published a couple of studies about looking at continuity and looking at comprehensiveness and arranging the clinicians into quintiles or quartiles of how good or not so good their continuity and comprehensiveness were, and then looking at that in relationship to spending and utilization. And what we were able to demonstrate is that both of them independently have about a 15% reduction in total cost of care. Total cost of care, not primary care, total cost of care. And they're both reduced hospitalizations by about a quarter or more. So when I've had arguments with CMS about why they should adopt these as measures of primary care, I've usually ended with, please show me another measure that has this level of impact, and I'll be quiet. I will stop jousting with you. And last week, they turned down our continuity measure for the second time. It's very, very frustrating. One of the added benefits of comprehensiveness is that we've been able to demonstrate it's associated with a 30% reduction in burnout. So family physicians who care for their patients in the hospital or who deliver babies or do both are less likely to be burned out. Now, we've asked ourselves many times, why is that? Because it seems like a lot more work to follow your patients into the hospital. And we think it's because, one, it gets them off the hamster wheel of outpatient care. And the second is that it leverages their relationships. They get to use those relationships and follow their patients and care for them regardless of setting. And that has a real intrinsic value that we often forget about. I want to shift to workforce for just a minute. This is over a decade old. We looked at primary care density by state and then its relationship to total cost of care. And others have done this as well. We were looking specifically at family medicine, and what we found is even if we controlled for rurality, poverty of the population, education level, there is a relationship between density of primary care and cost. The higher the density, the lower the cost. And yet we've never really leveraged this in terms of making sure that we have adequate workforce across the country. Bruce Landon and others at Harvard kind of came forward and just a couple years ago published another study showing that if patients who receive primary care are more likely to have high value care, they're a little bit more likely to have low value care, but they're more likely to have better health experiences, whether you measure that from a patient perspective or just looking at the course of their care. So another issue about the relationship and the utilization of primary care. Jim Machinko, who worked with Barbara for a long time and helped her develop some of the international comparisons, demonstrated that if you look at premature mortality across developed countries between 1970 and 2000, those who had a measurably higher primary care score on 7 different factors, and then later 12 different factors, did better on mortality and over time. Now, those who have a lower primary care score, like the United States, also did better over time, but there's a gap there in mortality that is important. Steve Wolf, who's a family physician, chaired the Institute of Medicine report on shorter lives, poorer health that came out in 2013. And one of the things they showed there is that, yes, these red dots, which are life expectancy for women in the United States, while it did generally trend up over a couple of decades, it was a race to the bottom for us in terms of other developed countries and what they experienced in improving life expectancy for women. And in fact, if you looked even before the pandemic, certainly during the pandemic, where we lost ground on life expectancy, it's a little unclear how long it's going to take us to get out of that gap. But looking back decades, we were already falling behind. And in fact, they also had this nice graphic looking at years behind the leader. How far is the United States, the red line, in terms of years of the probability of dying between 15 and 50 for women? We were falling behind for a long time. The folks, the gray line is actually demonstrating that they were improving years of life lost. We were falling further and further behind. And this is Barbara's question from 15 years ago. Does primary care reduce inequity in health? And she said yes. That density issue that I talked about improving cost, that density issue also improves life expectancy. And she said, every time you add a primary care physician to an area, it's associated with 1.44 fewer deaths per 10,000 population. And that impact is even greater for African Americans than for whites, largely because of lots of structural long-term issues, but access to care is another fundamental one. And Michael Marmot, does that name ring a bell for folks? He actually created social determinants of health as a topic at the World Health Organization at the UN 40 years ago and has really helped advance it as an idea of something to focus on to improve health outcomes. He said there's no question that part of improving health in poorer countries is as enricher as the provision of comprehensive primary care. And this is based on his studies showing that other countries have better health outcomes than the United States, and that it's not just a gap, it's that they have compressed the inequities. They have compressed the disparities in health outcomes in their population while ours has widened, so that people at the lower end of the spectrum in terms of poverty or education experience poorer health outcomes now than a decade ago. Most other developed countries have improved that. And so we decided to reproduce this a couple years ago with colleagues at Harvard. And what we found is that for every 10 additional primary care physicians per 100,000, or 1 per 10,000 if you want to stick with Barbara's scale, we found at the county level there was about a 50-day increase in life expectancy on average for every person living there. And if we took that down to another geography called the primary care service area, and this is something that Dartmouth created using data to show where people get their primary care. So it's geographies of care for primary care. We found that was almost 117 days of increased life expectancy. So the differences within those geographies have a really big impact on life expectancy. And then while we were working on the National Academy's report, we published another study showing whole county health professional shortage areas. the people living in them on average have almost a year of less life expectancy. And this is about workforce density. If we could increase up to the HPSA threshold of one primary care clinician per 3,500 people, everyone living there on average would have 22 more days of life expectancy. If we could get up to 1 to 1,500, a more sensible level, it's about 56 days. And yet 40% of the counties in this whole country are HPSAs, and 1,000 of them have been HPSAs forever. You know, National Health Service Corps, FQHCs, we've not been able to make a sufficient dent in these counties to move them out of that status. And in fact, this is July 2022 data that shows almost every county in Texas is a whole county health professional shortage area. Now, I really appreciated seeing the Texas Medical Association's report saying that perhaps 29% of these will be coming off that list. That's fantastic, but it means that the majority of counties still will be HPSAs in Texas, and that most of the people in these dark blue counties, on average, will have almost a full year less life expectancy. I was intrigued when the ACA happened and many states decided not to expand Medicaid. There were several red states that decided we're not going to do that, but we will do the 1115 waiver, we'll do DSRIP, we'll do Medicaid in a different way. Texas's 1115 waiver stipulated that they had to do a statewide assessment of primary care and mental health accessibility. And they did it through what were then the 20 regional health partnerships, which I understand have been dissolved or morphed into something else. And they did it through the nonprofit hospital community health needs assessments. So all the magenta, my daughter tells me, counties are areas with existing workforce need. The blue areas were the areas where dollars were assigned to try and implement some new workforce plan to meet that need. I'm struck by most of the state, particularly for mental health, not having a strategy based off of that needs assessment. I still want to applaud the blue areas where an effort was made. My more basic question is, and Texas is one of the states that is underfunded from Medicare for graduate medical education, just historically. And its Medicaid contribution to that, when you put them together, it's almost $500 million. And again, the TMA report was helpful for me to see other investments that have been made more recently. But the question is, how do you want to spend $500 million a year in Texas to change those magenta counties? And can we get enough political will to say, look, we're really going to make these counties a priority, and we're going to make primary care a priority in doing so? So that's an open question. I put that to TAMIST a few months ago, and I got crickets. And part of the problem, and this, I'm sorry to keep going back to the past, this is a decade ago, and based on data that were 15 years old. When you look at the outputs of our academic health centers and residency training programs in this country, even then we were down to less than a quarter of our trainees going into primary care. And that's without our being able to take out hospitalists. So you can't even sustain the current workforce we have as a proportion of all physicians putting this out. You can't do it. And yet we're a decade later and it hasn't gotten any better. So that's a big problem. It's why we're seeing active erosion of the primary care workforce in rural areas. And if you saw the American Board of Internal Medicine's report last week, it came out in May, it was using Medicare claims data. They looked specifically at internal medicine, where more than half of our graduates go into a subspecialty, another third go into hospitalist roles, and we're down to about 13% going into primary care. In the appendices, you also see where they looked at family medicine and showed a doubling of family physicians going into hospitalist roles, which is the same, basically, percentage that we see from our data. And we also know another 5% are going into emergency room or urgent care. So we are effectively losing our primary care workforce, even from the primary care potential. And a few years ago, we looked at nurse practitioners and PAs using co-location data, and we estimated then that about 43% of NPs, about a third of PAs were in primary care. But right before the National Academies report came out, we got data from HRSA looking at national survey data, and they estimated less than 30% of NPs. And the AAPA came to us with data that said less than a quarter of PAs were in primary care. So there is a common thread here. There is a common problem that we are losing workforce across clinicians, not just in the physicians. And that's an important issue. Now, Fitzhugh Mullen published an article about 20 years ago called White Follows Green, that our medical students make choices about their careers based on the income and the income differentials. We decided to do a play on that, looking at do hospitals, with hospitals' choices about expanding residency training, does White also follow green? And if you looked at the data between 1998 and 2007, the numbers, the percentages in parentheses are how much those subspecialists' incomes went up. So radiology went up by 25%, dermatology by 40%, anesthesiology by 21%, whereas pediatrics and family medicine lost ground and internal medicine barely held it. The slope is the growth of PGY1 slots as hospitals expanded residency training. And it was highly correlated with this income gap. And now why is that? Well, it's because they need people to work on their more lucrative services in the hospital. And so they used GME to populate those lucrative services. It's a very sound economic decision, but it is not a decision that helps our population health. And federally, we put about $19 billion a year into that training platform. It begs the question, should we be doing differently? So I come back to the report. So all of that pressure, all of that data led us to the need for a new report about primary care, because it had been 25 years since the National Academies had done anything really around primary care. And we had an unusual statement of task. So a committee has to work within the boundaries of their assignment. So our assignment was certainly to update how we strengthen primary health care, building on what the 96 report had in it. And we were asked to use the report to help bring the United States into a more international context, because the 40th anniversary of Alma Ata had launched a new international primary health care effort. So how do we bring the U.S. into that as a partner? But the most important and unique element was that we had to develop an implementation plan. So looking back at 96, everyone who was involved in that was still alive said the problem was we didn't have an implementation plan, we just had recommendations. So we had a very unusual challenge. It turns out to have been quite good. The definition from 96 was pretty good. The definition that Barbara Starfield used as well, but we thought it was time to contextualize it and speak specifically to the changes that needed to happen. So this was our definition, that high-quality primary care is the provision of whole person, integrated, accessible, and equitable health care by an interprofessional team that's accountable for addressing the majority of individuals' health and wellness needs across settings and through sustained relationships, but not just with the patient, but with families and community. So that's where we arrived as a committee. And each of these elements speak to measurement, but also speak to where we need to get to in terms of payment and other issues. We didn't relitigate the evidence for primary care, but we did update it, and still, primary care is the only part of the healthcare system that results in longer lives and greater equity. It is weakening when we need it most, and there are bright spots, but we have failed to spread them, to make them more accessible to people. And we highlight a number of these in the report. One of the most critical things we point to is the fact that we provide a third of all care in primary care. We provide a third of all care, but we get 5% of total healthcare spend. And that's down from 15 years ago when we got 6.5%. In the subspecialty sector, it's a third of care and 17% of total spend. Hospitals disproportionately the other direction. And pharmaceuticals are just increasingly eating how much we spend in healthcare. But it means that we're out of the gate, we're under-resourced for the job that we have. And it's even worse in Medicare. It's about 3 to 3.5% of total Medicare spend is in primary care. Better in commercial, but far behind other countries. And yet, if you look at the bright spots like Rhode Island, which set a minimum primary care spend almost a decade ago, now up to 11.5%, they've demonstrated a 7-fold return on investment from that. And if you look at the primary care incentive payments, which lasted for 5 years after the ACA was passed, the Commonwealth Fund says about a 6-fold return on investment in terms of slowing down healthcare spending. And so there's other bright spots around the country, and now Oregon has followed Rhode Island's path. Colorado has at least started the implementation. I haven't seen it actually in action. Delaware has passed the necessary legislation, and now are measuring primary care spend as the next step. So this is happening gradually. We also said in the report that primary care should be a common good. There's kind of an unspoken rule in National Academy reports. You can't say we should have a nationalized healthcare system. This is as close as we could get. That if you're going to give everyone access to any part of the healthcare system, it should be primary care. So we should make sure that, because its value is so high, we should make sure that everyone who wants access to it can get it. And to do that, we're going to need specific policy and oversight to make sure it happens. That's part of the implementation plan. And we're going to need very strong advocacy at the state level and at the federal level to make it happen. And that's why I'm glad to be here today. So we had 16 recommendations under 5 objectives. The first one was to pay for primary care teams to care for people, not doctors, to deliver services. Now, this is not a dig on doctors. This is about fee-for-service. This is about the need to have comprehensive teams to do comprehensive care, and that we need to change the model. The second was about ensuring access. The third was about training. The fourth was about electronic information services, and the fourth was the implementation plan. And I've kind of put little emojis next to them. The payment, I think we're laying bricks. We are laying bricks and making some progress, but it could fall apart if we don't keep doing that. Access is really, we have such a Band-Aid system in this country. It is just such a hodgepodge that it needs some overhaul. Training is the one objective in this report that has no champion yet. So that's why I emphasize it very heavily. It has no champion yet. It needs to be restoked as a flame. The EHR piece, we're actually getting a lot more data about, and I put a baby next to it because, once you have a baby, you can't give it away. We're stuck with this. This baby is not maturing very fast, though. It is not helping us. We're helping it a lot. We're putting a lot in and not getting anything out. And it, frankly, stinks a lot of the time. So we need some serious work there. But the implementation plan is actually making some headway. It's starting to take off, and I'm most encouraged by that. I'm not going to go through all of the objectives. I'm going to spare you that. I put the payment ones in here just to show you that the objectives are broken down into very specific recommendations with very specific actors named in most of them. So we really tried to be focused. But Primary Care for America's Health, a consortium of specialty societies and payers and health systems, is pushing into a new payment model. The Primary Care Collaborative, or TPCC, who's been around for 16 years now, has really made this a focus for them. The Innovation Center at CMS is developing a new payment model that I'll talk about in just a little bit more depth. And then we have new models like ACO REACH that have come out that have some interesting elements to them. So Primary Care for America's Health and the PCC both focus on payment models, with PCC also being the ongoing champion for state-level minimum primary care spend and tracking it regularly. The new model that CMMI is developing, it still has to go through the actuaries, but they learned from CPC Plus that we need to have a runway. We need 8 to 10 years, not 3 to 4 years. We need more up front. We need more capitation. We need more meaningful measures. So they're really listening, and I know that they're talking to people in states about this as they're developing it. The ACO REACH I put into here because it has primary care capitation separate from global cap. Wow. To be able to have accountability for what's put into primary care versus everything else is really critical, because usually when you give a health system money, you never know where it goes. And then the second thing is aiming for 7% of total spend. While that's not the 10 or 12%, it's twice what Medicare spends now. It's a good start. And to have it in policy, that's excellent. The other thing I'm excited about is that our report directly influenced the Office of the Assistant Secretary for Health to create the initiative to strengthen primary health care. This has been a year-long effort within OASH to get their colleagues within HHS together and say, we have important health problems in this country. Primary care is a strategy for addressing most of them, whether it's health equity or resilience from the pandemic or opioid recovery, opioid epidemic or mental health. Primary care is at the heart of all of those. We need to develop interagency plans to strengthen primary care to address these. They had a request for information that closed last month. They're supposed to come out with a report this month or next for the secretary to say, yes, you should stand up a secretary's council that coordinates primary care strategy. We have never had anyone in the federal government who wakes up every morning and says, how is primary care doing? This is the path to that. So I'm suggesting that you watch that very closely and weigh in. Even though the request for information is closed, anything that comes over the transom, anything the secretary sees, that Texas sees this is important, Virginia sees this is important, that's critical. They need to hear that because there's a lot of pushback that's going to happen in setting this up. The second thing is that this is starting to happen at state levels. We're seeing it happen in Massachusetts, we're seeing it in California and Virginia. You have a platform here that could become that, but something that advises the state on what primary care needs next. What are the priorities and what does it look like when it's in place? We need to have that kind of a coalition at the state level. The third is back to workforce. I'd love to have a state take the lead in how we repurpose dollars for GME, and there are other states that are starting to take a look at this. But accountability is a red issue, not just a blue issue, and sometimes you can get a legislator to see this as, hey, why aren't you helping my folks in rural areas with what you're putting out of your academic health centers? So I'd encourage you to think about, where are the opportunities there? And then last is payment reform. I don't know if Texas has made a run at minimum primary care spend, but it'd be great to have you all at that table. And then about Medicaid options. In the report, we talk about Medicaid to Medicare parity. It's in law, it's just never been enforced. And a state could take it on, not just as we're going to do this, but it is a federal and state issue to make this happen. And it is so critical to access. It's so critical to being able to support primary care teams that I'm here to encourage you. The report offers a very nice blueprint and support for that. So thank you. I will stop there.
Bob, what a wonderful presentation. And you kind of read our minds in some ways because we put together a large body of experts in the state that have been really looking at how can we get our legislature to address these issues about primary care. And so we have some really good things coming along. And the other thing is that next year we're going to have access to the claims databases throughout the state. And I think that's going to open a lot of avenues for exploring these transformative changes. So there's a few ways that we can get the members of the audience to ask questions. You can actually submit it through the app, or you can come up to the microphones. And I'm going to take the prerogative as the moderator to ask a few questions myself. And one of them came to mind recently when I was listening to a podcast from the Commonwealth Club of California, and they had a guest on who is a psychiatrist who is kind of the leading authority on one of the things that we're all dealing with right now, and that is the polarization that our country is facing right now. And his expertise is around conspiracy theories and disinformation. And he made some comments, and it made me think about the role that primary care can play in this. And one of the things that he said was that conspiracy theories and misinformation are because people have found themselves distrusting parts of the institutions and individuals in the country. And that word, then it occurred to me that primary care providers have a key element that very few other entities do in this country, and that is that the patients and their families trust the primary care provider. And that element, I think, strengthens the ability then for the primary care provider to play a role in to overcome some of these obstacles. And he brought up two ways to deal with conspiracy theories, and I thought they were something that we could use in the primary care setting. One is the way he put it, inoculation, and he's not talking about vaccinations. He's saying plant the thought in the person's mind that helps them to see that you need to evaluate what you hear and not just accept what you hear. The other thing he said was, instead of debunk, pre-bunk, which he meant that bring up something, and he gave the example, you may have seen some people talking about that they think that vaccinations plant chips in people's arms so that they can be followed around by the government. And he said there's actually been a study that looked at post-vaccination people and did examinations to prove that there were now chips in their bodies. So planting that idea during the visit is a form of pre-bunking. And so that was just one observation that I wanted to do. The other thing, though, is news this past week of CVS acquiring Signify Health made me think about when, in 5 years, when you ask somebody who their primary care provider is, are they going to say CVS? And the corporate takeover of primary care and private equity acquisition of primary care are things that are really going to be challenging, I think, as the future evolves here. And Signify, you may not know this, is a company that specializes in home visits and value-based care. So there's going to be maybe a blossoming of home visits and getting back to that kind of part of being a part of primary care, which may be a good thing. So I just wanted to, thinking about the future, how can we envision that as part of our future? And I'm wondering if maybe that's something that you can take back with your group and others to be contemplating how this is going to evolve over the next 5 to 10 years.
So I'll use both of those examples for your question. I think there's a real opportunity to help CDC understand the value of primary care in dealing with epidemics. They've been stunned. We've been working with CDC for the last year and a half, and they've been stunned most recently to know that half of our registry practices were giving vaccines throughout the epidemic, but never got COVID vaccine, and had no data from HIEs or other sources to know which of their patients had received COVID vaccine. So we're failed on both fronts, on getting vaccine and on having data flows that tell us who's been vaccinated. It makes us a weaker partner in trying to make sure that those conversations, pre-bunking or debunking, lead to someone getting vaccinated. So I think helping CDC understand that, and the shakeup that Mary Wakefield is going to be leading at CDC, I think, is a critical window for us to do that. The second piece, it's been interesting to me that there are a number of industries that think that primary care is, because there are so many visits and there's so much face time, it's an opportunity to sell things. So whether that's CVS or Amazon, that's a misuse of primary care and its relationships. The second is that some of these hedge funds and private equity groups have actually understood the data that I walked through, but they don't understand the fundamental part of it. So some of them are buying very primary care, well-driven systems, and some of them are buying other stuff and thinking it's all the same. And that just making sure that people have face-to-face visits or on a screen with someone counts as a primary care visit that has this kind of effect. They don't understand. And so I think they actually can be helpful to us in pulling more resources into primary care and developing good models, but we need to be a partner to them to explain what good primary care really looks like.
That's great. So Robert Jackson is stating that the data is irrefutable. Why don't the policymakers listen and make the necessary changes to transform our sick care delivery system?
Robert, I think part of it is that there is no one that wakes up every day wondering how primary care is doing. If I learned one thing about what policymakers think primary care is, they think it's FQHCs. And that's not bad. It's just incomplete. So they think when they push resources over or put vaccines into FQHCs, that's primary care. It's stunning how many people think that. And they need to understand that this is actually a larger system that needs those resources, those vaccines, that support. And it's not something that HRSA or CMS or any of the single agencies can do. It's what they need to all be working together on. And I think the Federal Secretary's Council is our next best opportunity to try and create that kind of infrastructure and understanding.
Great. We've got about 4 minutes left. Let's start here at the speaker.
So I loved your information, not surprising, around the decline of primary care providers in the community, right? Like we've seen a significant decline. I'm curious to see what those numbers are around mid-level providers, like nurse practitioners and physician's assistants, because also promoting that level of provider in the workforce helps our primary care providers be able to work higher in their license level, right, at the top of their license, and fill more of that generalist gap to keep people in primary care rather than specialty care. Do you have numbers on mid-level providers? Do you have a sense on how that's working?
No, thanks. So we're seeing a decline in NPs and PAs working in primary care as well for the same reason. They can be paid more for a narrower scope of work with more controlled hours. I mean, it's not unique to them, not unique to us. And yes, I think Chris Sinski has done nice work around this, that having everyone working to the top of their ability, not licensed, top of their ability, investing them in the care of the patients so that we're not competing for the same kind of scope. We're competing for what can I do to fill this bit more comprehensive care approach to this patient. And it means that we may need to shift some of what we do too. But I think figuring that out is one part of the problem. The other is how do we keep them and get them to come into that role? And those are mutual, not exclusive problems.
Over here.
Hi, thanks. My name's Eliza Norwood. I'm an internist here and worked at community care for a while. And I wanted to bring up a couple points and see what you think. They're kind of interrelated, but both GME and actually practicing in a primary care clinic, especially for our underserved patients. We absolutely need more time with patients. I think your point about coordinated care is necessary, but not sufficient for the kinds of patients that we see who, it's very difficult for them to get into clinic. They have many comorbidities, and this 20-minute visit kind of model just doesn't work. And so when we're talking about GME and the burnout and losing, new trainees coming into primary care, I see what our residents see in the clinic, and they are scared because it is untenable, the amount of work that we have for these patients. And so what are your recommendations? So we will absolutely lose people, I think, massive levels of burnout because you're seeing patients every 15 minutes who have many, many complex needs. They need the social worker, but they also need all of your higher level medical care in that visit for multiple problems. So and I've tried to advocate at both local local levels, just even within our clinic, and there's this 20-minute visit mindset that's very hard to break, even when you try to talk about modifying that for patient complexity. Are there any tips you have of how to get that across, both locally and at a larger level?
Ooh, that's a tough one.
I know, it's not really an answerable, but that's the main problem, I think, with a lot of them.
No, it is tough. I actually, in my own clinic, where I've been for 18 years now, I actually 5 years ago went to him and said, I can't do this. I need 30-minute visits, and I'm willing to take a pay cut to do it. Just, I can't do it. And precepting for our new residents this last month, especially since we put an urgent care into our clinic where all of the acute care stuff goes, I look at these residents and I'm like, oh my gosh, this is such a complex patient that you've just met. We have to flip the business model where the role of primary care is to take care of those people and do it well, because the objective is to keep them out of the hospital, keep them out of the emergency room. And it's not just about time, it's about team. And if you look at the VA, and for those of you who work in the VA, you're going to shake your head at me, but the plan is smaller patient panels, so they're aiming for 1,200 patients per clinician, bigger teams, more time, because the VA, every hospitalization is an expense. And that's the flip that has to happen to make this logical. Or in value-based payment models where your revenue, your margin is no longer about increasing services, it's about decreasing costs. That's the other opportunity, and some of our leaders, even in those models, don't understand it. But it's that, look, if we're supposed to be decreasing costs to get to our margin, well then I need to do better at what I do, and that means more time and more support.
Well, thank you. We have unfortunately run out of time.
Thank you.
So I want to congratulate Bob on such an outstanding report.
Thank you, Dan. Thank you. And thanks for the questions.
And just so you know, I mentioned Alma-Ata last week in a presentation that I did, so, yeah. I'm a nerd that way, thank you. All right, that was great. I think that was a wonderful way to start out, and Dr. Phillips, Dr. Crowe did exactly what we wanted them to do, really put things into context, where we've been, where we are now, and where we need to go. So time for breakouts. Hopefully you have your mobile app. It's really slick and very helpful. So if you don't have the app, you can always stop at our desk and find out. We also would request that you fill out evaluations per session per CEU and sign in each date at the registration desk. And also, Stephanie sent me this. Due to hotel maintenance, we are kindly asking that these 2 cars be moved. Both blue BMWs, I don't know if they're related. One of them is license LSG 2044. The other is NFF 5085. So if you don't know your license plate, please do check. Thanks everybody, and please do join us after the closing plenary this afternoon at 4:45 right out there in the foyer for a reception hosted by our sponsors. Thanks everybody.